I invite the second speaker for this afternoon will be Dr. Nilanga Nishad. He's a senior registrar in gastroenterology. He graduated with MBBS from the University of Kelaniya, obtained the MD medicine from the University of Colombo, has an MSc in community medicine and a diploma in public health in epidemiology. And he has a high number of publications and abstract presentations with an H index of 4.0. So I'm sure he's combining his knowledge from epidemiology with his work to do good research. It appears so. So it's my great pleasure to invite Dr. Nilanga Nishad to speak to you on assessment and management of clinically significant portal hypertension, CSPH, in year 2022. Over to you, Nilanga.
Thank you very much for the kind introduction. Good afternoon, ladies and gentlemen. Today I thought of discussing some information regarding the assessment and management of clinically significant portal hypertension, which is relevant to the new year. So the outline of the talk would be, I will be talking about the portal hypertension, the clinical significant portal hypertension, and how it is measured, and the hepatic venous pressure gradient as a predictor of decompensation, and the non-invasive test, the FibroScan, and how it can predict clinically significant portal hypertension. The Bavino 7 guideline and the role of 5 liver stiffness measurement, the initial management, prevention of decompensation, and a new concept called recompensation. Anyway, nearly 2000 years ago, the famous Roman anatomist Galen believed that the liver is the principal organ of the human body, and also he thought that liver is the organ that produces blood to be distributed throughout the body. Still, I know most of the gastroenterologists believe the liver as the principal organ of the body. The first drawing of the portal circulation came in the famous anatomy book called De Humanico Paris Fabrica in 1543. Now we know that the circulation of the liver is with this portal venous blood flow. The portal vein takes the nutritious blood from the gastrointestinal tract to the liver, and the liver via its hepatic vein through the inferior vena cava take the blood into the right side of your heart. So simply, the portal hypertension is increased pressure within this portal circulation. More than 5 millimeter mercury, that's the normal level. So how does this portal hypertension happen? It has to be obviously some blockage in this system. So it can be prehepatic or it can be post-hepatic blockage. Further complicating the matter, the liver, the architectural or the structural changes in the pre-sinusoidal, the sinusoidal and the post-sinusoidal area, the most complicated histology I can remember in my school days, will lead to the portal hypertension. So anyway, the clinically significant portal hypertension is defined as elevated hepatic venous pressure gradient more than 10 millimeter mercury, where all the disastrous complications begin to occur in a patient. So why do people get portal hypertension? Obviously, the red arrow shows that it is most of the time due to cirrhosis. The cirrhosis can be non-alcoholic fatty liver disease, or it can be alcohol-related liver disease, or viral origin, or any other etiologies. So from top to bottom, you have so many causes: the Budd-Chiari syndrome, the intrahepatic pre-sinusoidal causes, schistosomiasis, the hepatic fibrosis, so many medications, toxins, and the sarcoidosis, as well as further down in the liver, the portal vein thrombosis due to any cause can lead to portal hypertension. Why it's important? Because the NAFLD, the correct term at this moment is metabolically associated fatty liver disease epidemic, is real in this world, estimating global prevalence to be 24% in 2016. And Professor Dasanayaka and team found in 2009 in the Ragam Health study the NAFLD prevalence to be 33% and 6.2% incident rate was recorded in 2017 by Prof. Nirial and team. But unfortunately, we don't have enough data on the other things. So what Dr. Mananjala Senanayaka did in 2012, he evaluated the alcohol-related cirrhosis patients in Ragama Hospital in 2012 and found more than 50% of the cirrhotic patients coming to hospital are due to alcohol. We don't have the other data. Anyway, all the cirrhotic patients, most of them will have clinically significant portal hypertension at some point of time. So why it is important to this audience, why the clinically significant portal hypertension is so significant? Because most of the patients will come with so many complaints. The neurological manifestation of hepatic encephalopathy, upper GI bleeding, the liver failures, hepatocellular carcinoma, ascites, bacterial peritonitis, hepatorenal syndrome are the complications of clinically significant portal hypertension. Pardon me, ladies and gentlemen, I will not be able to talk about portal hypertension without talking about cirrhosis, because that is that much common and that is the most etiology for the clinically significant portal hypertension. So if you think back, why do cirrhotic patients become ill and die? Now you can realize it's due to the clinically significant portal hypertension or the portal hypertension. So what I want to highlight is the decompensating events, the bleeding, ascites, encephalopathy, or the jaundice, etc., are directly proportional to the portal pressure. So if a patient is having portal pressure, the hepatic venous pressure gradient less than 10, most of the time they will be compensated over a period of time. If they have a higher value of hepatic venous pressure gradient, that is clinically significant portal hypertension, they will develop ascites, varices, HRS, HCC, etc., and further rise of the hepatic venous pressure gradient will lead to further disastrous complications. But the problem is how to measure the portal pressure. So you need a catheter to be inserted through a peripheral vein, intending that it will reach the hepatic vein to get the portal pressure. Further, at the wedge pressure level, so you will get a difference and you will measure the hepatic venous pressure gradient. Now the newer modality is you cannulate your hepatic vein through an upper GI endoscope and get that value, and further down in the endoscopy you go to the stomach and you cannulate again the portal vein and you will get a pressure difference, that is the hepatic venous pressure gradient. So is it practicable? Of course not, because it is invasive and interventional procedure that requires so much hi-fi stuff. And most terrifyingly, it's performed under sedation and the anesthesia and the extra cost. And it is an increased risk for a diagnostic procedure. more cons than the pros. So, up to now, what we know, decompensating events, it's related to the portal hypertension. So, if there are any other things that can predict the portal venous pressure or the hepatic venous pressure gradient, that is marvelous. So, we have that. That is called elastography or the fibroscan, and with some of the biochemistries and the hematology. So, the liver stiffness measurement with the fibroscan is the answer, my friends. So, it will examine a volume 100 times bigger than a liver biopsy, and it has been validated with the histology, and the values are disease specific. NAFL some value, and the hepatitis B some value, hepatitis C some value, and it is dependent on the body mass index also. So, how to measure the liver stiffness? It is with the transient elastography or the fibroscan that is available in Sri Lankan setup in Bragam Hospital, and I think in the Kandy Hospital, as well as in some private sector hospitals. There are so many other imaging modalities that can measure the liver stiffness measurement that is not practiced in our setup. Therefore, ladies and gentlemen, how to refer a patient for a fibroscan? So, as a physician, with your smartphone in your hand, with some basic investigations, you can measure the FIB4 score. If it is less than 1.3, you can exclude clinically significant portal hypertension by excluding the fibrosis. If it is more than 3.2, that's obvious that the patient is having fibrosis. In between those two, you have to go for fibroscan. There are so many other non-invasive tests and the predictors also. So again, going away from my topic, I have two patients for you. One is Mr. Sirisena and the other one is Mr. Nandasena. Obviously, the ages may not be correct. Look at this and think which patient has a higher risk of fibrosis or the clinically significant portal hypertension. Yes, obviously, people think Nandasena is correct, but he is not always. The poor guy, Sirisena, I calculated with my smartphone, found to have a FIB4 score of 1.93. Obviously, he is having cirrhosis. Obviously, he is having fibrosis. He is not aware that. And Nandasena is well aware that he is doing well at this moment. Anyway, Sirisena needs a fibroscan. Both of them can buy at least 10 machines because one fibroscan machine will cost around US $50,000. $50,000 with a maintenance cost of $8,500 per year for the maintenance. So it will give the liver stiffness measurement with the kilopascals. So again, I want to highlight that the decompensating events are directly proportional to the portal pressure, which is directly proportional to the fibrosis. So the first thing is proportional to the last thing also. Anyway, in there's a small city in Italy called Bavino, where the first meeting regarding the portal hypertension as well as the cirrhosis took place in 1990 with some gastroenterologist and hepatologist, and they met for the 7th time in the same venue few months back, and they gave consensus and recommendations. They told a new term called compensated advanced chronic liver cell disease, that is actually cirrhosis, compensated cirrhosis. They want to make a continuum between the fibrosis and cirrhosis. Anyway, the words may be same. So what they are recommending at this moment is the transient elastography or our fibroscan can use for early identification of clinically significant portal hypertension as well as developing decompensation and liver-related death in cirrhotic patients. So with the fibroscan, if the liver stiffness is less than 10, you can rule out cirrhosis. If it's between 10 to 15, it will suggest compensated advanced chronic liver disease. If it's more than 15, that is highly suggestive of compensated cirrhosis. In a cirrhotic patient, if you measure the liver stiffness and if it is less than 10 kilopascals, he will have a negligible 3-year risk of decompensation as well as liver-related death. You can go for invasive methods in individualized manner at the referral centers such as liver biopsy or the hepatic venous pressure gradient if you want. So we talk about diagnosis of cirrhosis with a fibroscan. Now we are talking about the diagnosis of clinically significant portal hypertension in patients with compensated cirrhosis. So non-invasive tests are accurate for estimating clinically significant portal hypertension. If it is the liver stiffness less than 15 with a platelet count of more than 150, again you can rule out clinically significant portal hypertension in patients with cirrhosis. If it is more than 25, you will rule in the clinically significant portal hypertension, especially in virus-related, alcohol-related, and non-obese NASH people. The problem arises between 10 to 25, where you need to go for something called anticipate model. In Baveno 7 criteria, they mention if somebody is having a liver stiffness between 15 to 20 coupled with platelet count less than 120, he is having clinically significant portal hypertension, as well as between 20 to 25, if the platelet count is less than 150, again, he is having clinically significant portal hypertension. Between 10 to 15, the rule in is a problem because of lack of data. Ruling out, as I mentioned in the previous slide, they have given the recommendations. So, the Baveno 7 guideline, they are telling the rule of 5, that is 10, 15, 20, 25, more than 25, that are denoting the progressively higher relative risk of decompensation and liver-related death independently of the etiology of the cirrhosis. Anyway, the liver stiffness measurement is a good diagnostic tool as well as it's a good prognostic tool. So it is useful both at the index and even at the follow-up. So how to monitor the patients with cirrhosis? If the liver stiffness is between 7 to 10 and ongoing liver injury, which will be evident by the biochemistries, you have to monitor the patient on an individualized manner. If the patient is having compensated cirrhosis, you can do your stiffness measurement every 1 to 3 years. On the other hand, if a patient with cirrhosis has a decline of liver stiffness measurement more than 20%, who are having less than 20 kilopascal liver stiffness or any decrease to obviously less than 10, we can jolly well say clinically significant decline of the liver stiffness. That is also associated with substantially reduced risk of decompensation and liver-related death. The new concept, the spleen stiffness measurement. You will come across a patient with portal hypertension. The bleeding, upper GI bleeding is there. You check the liver is normal. So what to do? What we can do is we can put the probe to the spleen, and if the spleen stiffness is higher, we can rule in clinically significant portal hypertension. That is more practicable and very easy. So how to prevent the first decompensation in any cirrhotic patients? The beta blockers, the non-selective beta blockers, they will prevent the decompensation in patients with clinically significant portal hypertension. The carvedilol is the preferred drug. It will reduce the hepatic venous pressure gradient and has a greater benefit to prevent decompensation, and it's better tolerable, as well as it will improve the survival. The banding or the glue injection will not obviously prevent ascites or encephalopathy. That is only symptomatic treatment. And high risk varices and patients having contraindications or not tolerating beta blockers, you have to go for banding. There's no other options. There are few options other than the upper GI endoscopy. And mind you, there's no indication to use beta blockers in patients without clinically significant portal hypertension. So people will have some gray area in this area. They want to start the beta blockers, but you have to show that patient is having clinically significant portal hypertension. So why carvedilol? I have already answered. The carvedilol has been shown with so many studies as it is better than propanolol at this moment. And the other important aspect is the etiological management of cirrhosis. That is removal, suppression of the primary etiological factor. What does that mean? That is sustainable virological response in hepatitis C virus or HBV, hepatitis B virus suppression in the absence of co-infection with hepatitis D in chronic hepatitis B virus patients, and long-term abstinence, at least more than 1 year, in alcohol-related liver disease. So with these, you can achieve the resolution of clinically significant portal hypertension with management of other comorbidities such as diabetes management and the control of the body weight and etc. And the other impact of non-etiological therapies are the statins. Statins has shown that it will decrease the portal pressure and improve overall survival. The drug of choice is the simvastatin. You can use in child's A and child's B. And keep in mind the lower dose of simvastatin, because the muscle and liver toxicity it can aggravate. And child C cirrhotic patient, the simvastatin has not shown any promise. And aspirin should not be discouraged in this patient. It will reduce the risk of hepatocellular carcinoma and liver-related complications and even death. The other non-etiological therapies are the primary antibiotic prophylaxis in GI hemorrhage. These are the recommendations given by the Baveno 7 guideline. In child C cirrhotic patients with low protein at ascitic fluid at high risk of SBP. So those also can be given primary prophylaxis. The rifaximin, all of you know, for the hepatic encephalopathy. The norfloxacin is the drug of choice for bacterial peritonitis. And anticoagulation is not discouraged because it is also reduce liver-related outcomes with or without portal venous thrombosis, and it will improve the overall survival also. Direct oral anticoagulants can be used in child A and child B. That is not recommended in child cirrhosis because of unavailability of the studies. So how do you prevent further decompensation? You have to consider for the liver transplantation. No options from there onwards for cirrhotic patients. Screening endoscopy and the transjugular intrahepatic portosystemic shunt for recurrent ascites. For varices, the carvedilol and banding depending on the size and the nature of the varices. If the patient is having hypotension or the hepatorenal syndrome or AKI, you need to stop the beta blockers. Of course, for patients not tolerating beta blockers, banding and ligation. For portal hypertension, gastropathy with bleeding, beta blockers are beneficial after excluding gastric antral vascular ectasia. So this is what transjugular intrahepatic portosystemic shunt, the interventional radiologist will put a stent between the hepatic vein and the portal vein to make sure there's a free flow between those two in order to reduce the hepatic venous pressure gradient. So now comes to the new concept called recompensation. So we talk about diabetes and keto, why we are lacking behind, we are having recompensation. So the removal or suppression or cure of the primary etiology of the cirrhosis, you need to control the primary etiology. Then resolution of the portal hypertension related things. The resolution of ascites without diuretics and without hepatic encephalopathy of lactulose and rifaximin and absence of recurrent variceal hemorrhage for at least 1 year. So the etiology is controlled and the symptoms are controlled. So then you go for biochemistry and see the albumin, INR and bilirubin are normal or not. If those are normal, then that is called as recompensation. Those patients are coming to our clinics. We have seen them. And but the problem is the clinically significant portal hypertension, as the aluyata gindara will be there. They persist despite the recompensation. The beta blockers should not be therefore discontinued unless the clinically significant portal hypertension resolves. And absence of decompensation after treatment and still with altered biochemistry cannot be labeled as recompensation. For few words regarding these venous occlusions, the long-term anticoagulation is required for Budd-Chiari syndrome, and angioplasty, stent, thrombectomy, thrombolysis, TIPS, or the liver transplantation may be the ultimate treatment option. And the portosinusoidal vascular disorders, the portal vein thrombosis, need hematology workup and anticoagulation after treatment for the varices. Of course, the exercise and weight reduction also has shown that they are also reducing the portal hypertension. So, ladies and gentlemen, finally the take-home messages. The clinically significant portal hypertension, that is less than 10 hepatic venous pressure gradient, will predict the decompensation and liver-related death. And the fibroscan can predict the clinically significant portal hypertension. What we need to highlight our government regarding the value of fibroscan, and some gastroenterologists believe it is the stethoscope of them. And carvedilol has benefits in prevention of decompensation, and simvastatin can reduce portal hypertension. Aspirin and warfarin are friends. They are not enemies of cirrhosis. And try to achieve recompensation for your patients. So thank you very much for your patience, for listening to me.
Thank you very much. Thank you very much. We have only about 1 minute left. May I invite the judges to ask any questions that they might have?
Actually, the fibroscan, at the moment, we are not doing fibroscans for the cirrhotic patients, madam. At this moment, what we are doing is for the gray area. If a patient is having FIB4 score more than 1.3 and less than 3.2, then we are going for the fibroscan. At this moment, in Sri Lankan setup, we are not practicing to identify clinically significant portal hypertension with the fibroscan. What we do is, we are going to identify the fibrosis with the liver stiffness. But it can be used if we have enough fibroscans in the country.
Okay, thank you.
Right. Thank you, ma'am. Right. Okay, it's my pleasure, Dr. Nilanga, to present this certificate. On behalf of the